My name is Chuck Perlman from Boston Scientific, and it's a great honor to be here with an esteemed panel. We've been observing this space of bariatrics for some time, and with the recent acquisition and integration of the Apollo Endosurgery team and technologies into our portfolio, we've been able to step into a leadership position in this space. And today we are excited to have three expert speakers, along with one individual I think we all know at the end of the panel, who are going to speak to us about the field of bariatrics across a wide spectrum of topics, from medical treatment to endoscopic treatment through complication management. And as leaders in the field of endobariatrics and in GI in general, I think they've all served in leadership positions across relevant societies. They've been lead investigators on some of the important clinical research that's been done, and many are involved in actually the development of medical technologies in endobariatrics. I think they need no introduction, but I'll just do a quick one for everyone. Our first speaker today will be Dr. Shelby Sullivan. She's a professor of medicine and the director of the Endoscopic and Bariatric and Metabolic Program at the Center for Digestive Health in Dartmouth-Hitchcock Medical Center in New Hampshire. Our second speaker will be Dr. Bahram Abudaya, who is currently a professor of medicine at the Mayo Clinic in Rochester, Minnesota, but in November of this year will be transitioning into a new role as Executive Director and Associate Dean for Innovation and Director of Interventional Gastroenterology at Cedars-Sinai Medical Center in Los Angeles, California. And our final speaker, as well as serving as the chair for today's symposium, is Dr. Vivek Kumbhari, Professor of Medicine and Chair of Gastroenterology and Hepatology at the Mayo Clinic in Florida. And with that, I will hand off to our chair, Dr. Kumbhari. Thank you.
Oh, yes. Cheers. Thanks very much, Chuck and Boston Scientific, for the opportunity. I just want to acknowledge that this is also being live streamed, and so we welcome everyone on the live stream, and we thank you for your patience. We're starting a few minutes late. A huge honor for me to be able to chair this symposium. Being very grateful for Boston Scientific's energy in not only the endoscopic bariatric space, but also the flexible endoluminal surgical space. And I think, with their championing this space, I think we've got a very promising future ahead of us. As many of you are aware, Orlando Health leads many initiatives, but their obesity and bariatric program is also world-class, and they do some fantastic work in the bariatric surgical space, but also the endoscopic bariatric therapy space as well. So this is very relevant that Orlando Health is hosting this. When Dr. V asked me to pick speakers for this symposium, he said, I only have one request, that you get the best people for this symposium. And so I was left with no choice as to who to invite. And so Dr. Sullivan has been, and Dr. Abudaya have been mentors to me, throughout my career, both in the medical weight loss as well as the endoscopic bariatric space. I've been PIs of multiple studies, have had a huge influence on our field from a patient traction perspective, from championing this at the society level, and also in pursuing reimbursement. So thank you so much for joining us. And obviously, Dr. Hawes was one of the inventors and founding members of the Apollo group, which was the team that invented the overstitch endoscopic suturing system. And so obviously very grateful to him. So we'll get started. So first, Dr. Sullivan, who's already been introduced, would love you to tell us about the medical management of obesity in 2024.
Thank you so much for that very glowing introduction. And I'm going to try to get through these slides as quickly as I can. Here are my financial disclosures. So this is what we traditionally have thought about for the components of a comprehensive obesity treatment program. And I'm really going to be focusing on the pharmacotherapy side of this and lifestyle therapy. But we think about these different populations of patients with these different BMI categories of who we treat kind of in these areas. And the endoscopic bariatric therapy and weight loss medications are really, we think of as 27 to 29.9 plus a comorbidity, plus bariatric surgery, which new guidelines are recommending for a BMI of 30 and above. But this is primarily not yet covered by insurance. And again, we're really focusing on pharmacotherapy for today. And I know we're talking about medical obesity in general, but I'm really focusing on pharmacotherapy at this point because lifestyle therapy by itself doesn't really work great. And so we're focused on pharmacotherapy. There are lots of medications that we have available for us. You can see this on this slide. And previously, my algorithm for doing pharmacotherapy was what you can see here for the old algorithm. Stop medications, identify patients who will benefit from weight loss, like we just talked about on our previous slide, choose a weight loss medication based on other medical comorbidities, and then determine if you should continue the medication. And now, really what I do is we stop the medications, we discuss the fact that they have to be on these medications long term, and then if they've got coverage for it, I start semaglutide or tirzepatide. And if they don't, then I think about those other disease processes. But those are the two medications that I'm going towards right now for medications, regardless of what other medical comorbidities they may have. And then again, we determine whether or not they should continue the medication. And this really kind of demonstrates why that is, why there's this paradigm shift in kind of what we're doing. And it's because of the amount of weight loss that you see with these medications. So for tirzepatide and for semaglutide, you see over 80% of people are getting 10% or more total body weight loss. And for semaglutide, it's 70%. Sorry, these slides are moving forward. But when we look at even the 15% total body weight loss mark, 50% of patients on semaglutide get to that, and for tirzepatide, 70% of patients get to that. You don't have anywhere near that much with the other medications. So again, if they have coverage, we go to those medications. And why do they work the way that they do? Well, these medications are based off of GI, hormones, gut hormones that are produced predominantly in the small bowel. And GLP-1 really has this effect on food intake, decreasing food intake. We all know about the effects on gastric emptying, and we'll talk about that in a minute. And then it has effects on the pancreas as well. GIP is a little bit different, and we're going to talk about this in just a second. It actually does increase, in its native form, increases fat accumulation and doesn't actually have quite the same effect on food intake as GLP-1 does. But when we look at GLP-1 medications, we see that with this first step trial. Again, this is the data that we showed just before, but you see the huge weight loss that you see in these patients and really getting to 17% total body weight loss in patients who completed the trial. But we still have about 80% of patients who were able to continue the medication. So about 20% had to stop taking those medications. Tirzepatide, though, we see even more weight loss. Now, this is a GLP-1 GIP co-receptor agonist. So again, just like the Wegovy, we have to do a ramp up of that medication. But by comparison, so the completer in this study's completer got 22.4% total body weight loss versus that 17% in the step 1 trial that I just showed you. And I told you in the previous slide that GIP actually promotes fat accumulation in its native state. So how can this possibly be possible that you have a hormone that actually is kind of obesogenic? How can adding that to a medication increase the weight loss with it? Well, one of the big reasons for that is because in its non-native form, so either in a superphysiologic form or in a form that's resistant to degradation, it has the opposite effect. So it actually decreases food intake and has like a very suppressive effect in the brain, essentially, for suppressing food intake when it's in these forms. And again, this drug it has a 7-day half-life. This is a degradation-resistant form of this receptor agonist. And that is why it has the opposite effect. So then if we look to the future of the new agonists that are coming out, we have, again, this is not FDA approved yet, unlike tirzepatide and semaglutide, but retratide is a triple agonist. So that's GIP, GLP-1, and glucagon receptor agonist. So in this study that I'm showing you here, at the highest dose of the medication in patients who completed the trial, we have 24.2% total body weight loss. So this is even more than what we've seen previously. There is another medication, survodutide, which is a dual GLP-1 glucagon medication. And again, we see a lot of weight loss, not as much as the triple agonist, but we still see a significant amount of weight loss. This drug has some more dropouts because of side effects. So we'll see what happens with it in the future. But glucagon, and we haven't talked about this specifically up until this point, but glucagon is increased in obesity, native form is, and it's also increased in diabetes. So again, how does giving a glucagon receptor agonist, how does that promote weight loss and give you even more weight loss than you had before? Because not only that, but it increases the amount of glucose that's circulating as well, because it increases gluconeogenesis and it increases glycolysis in the liver. It also increases lipolysis in adipose tissue, so it increases your triglyceride and your free fatty acid levels, which also isn't great. But one of the key things that it does do is it increases energy expenditure and induces satiety in animal models. And there's evidence that this happens in humans as well. So you can see in panel A here that has the very top line is the glucagon. So if you have glucagon by itself, your glucose is going through the roof. It's really getting significantly higher. GLP-1, on the other hand, suppresses that. If you put them together, the GLP-1 kind of reduces that effect of glucose when you're giving it in conjunction with glucagon. So it attenuates that glucagon effect on their glucose in your serum. But the big thing that it does, and that's here in panel A, is it increases resting energy expenditure. So regardless of whether it's by itself or whether it's with GLP-1, it increases resting energy expenditure. Again, that's why you're seeing this additional weight loss with it when you're adding it to a GLP-1 GIP coagonist that's already present. So there are some downsides, though, to these medications. So these are all the great things, right? The great, wonderful things of these medications. They give you great weight loss, but they have some negative points to them as well. And one of them is related to the type of weight that you're losing. Typically, when you're losing weight, about 25% of the tissue that you lose is lean tissue and lean muscle tissue. In these studies, though, when you're comparing weight loss with semaglutide versus a different medication, an SGLT2 inhibitor for weight loss, or for diabetes in particular, in this study, weight loss was 40% came from lean tissue. Again, that's in comparison to what we normally see. So that's a problem. And I'm sure you've heard in the lay literature this quote unquote Ozempic face. So that's part of that sort of lean tissue loss that we see. The other problem, this is actually data from the SELECT trial. This was a study that looked at 17,000 patients, so a huge number of patients who had a history of cardiovascular disease. They had obesity, but they didn't have diabetes. They didn't do any lifestyle therapy, so they didn't have like a set schedule for follow-up that they had to do with these patients. Dropout due to adverse events was still, 16.6%, so not horrible. But the weight loss here is also not as much. So in the trials that I've showed you, weight loss for semaglutide, and this is what the SELECT trial used with semaglutide, weight loss was 15 to 17% total body weight loss. But in something that's more similar to clinical practice, we see that weight loss was actually only 9.4% total body weight. So problems with weight loss from more lean tissue than adipose tissue, and the problem of not having quite as much weight loss as we see in the clinical trials when we are doing these or using these medications in clinical practice. The other thing is that you can never stop the medication. So this is the step 1 extension trial where patients who were on semaglutide stopped the semaglutide and they saw what happened over time. And essentially they regained, of that 17% total body weight loss, they went back to 5.6%. So they regained about 11.9% total body weight percentage. So that was the subtraction. So they're really regaining most of their weight. The same thing is true for tirzepatide. So this was a randomized trial where they were on the medication for 36 weeks, and then patients were randomized to either continuing the medication or stopping it. They got to about 21% total body weight loss at the end of the 36 weeks. But in the patients who were then switched to placebo, you can see that they regained weight. So they went from having essentially 20% total body weight loss to 9.9% total body weight loss from baseline. And the reality is that they just lost more weight initially than the patients who were in the step 1 trial. So at some point, they're going to continue to regain their weight. It's just that they started at a higher level of weight loss. So the rate of weight loss is the same, but they're going to get back to baseline. And that's what we see in clinical practice. The other issue is that as we talked about in these other trials, they had about a 20% dropout rate, somewhere between 16 or 17 and 20% dropout rate because of side effects. But in clinical practice, only about 30% of patients are continuing to take these medications at the 1-year time point. And whether that's because of issues with how much the drug costs, because it's given to them for free if they're in a trial, or if it's really just related to these side effects, is not completely clear from studies like this. But it essentially tells us that a lot of patients are not continuing to take these medications. The other thing is how much it actually costs. So in the U.S., this data came from a medical claims database, essentially, that's looking at commercially insured members. And they looked at the entire cost of their care for that year. They compared it to the year before, and they compared it to a paired cohort that was done. It was a 3-to-1 matching. So there's 3 times as many patients in this control arm than in the GLP-1 receptor user arm. And this is specifically for obesity, not for diabetes. And you can see that in patients who completed a full year of therapy on this drug, that the annual cost of care was $25,000, almost $26,000 for the patient on the GLP-1 receptor agonist versus $11,600 for the patients who were not on the GLP-1 receptor agonist and were otherwise exactly the same. So the same level of obesity, same comorbidities, but there was no cost savings. It only cost them money. It didn't reduce cost of care anywhere else. And we see this when we look at our cost-effectiveness analyses as well. So this is another cost-effective analysis that just recently came out, and essentially it boils down to that for non-dominance, compared to like an ESG, for example, which my good colleague, Dr. Abadai, is going to talk to you about a little bit more, that at a cost of $16,360 for ESG, semaglutide has to cost less than $3,600 a year with 20% or fewer patients dropping out in order for it to be cost effective over 5 years. Well, we already know that it costs way more than that. We already know that more than 20% of patients on these medications drop off. So it's just not going to be cost effective in any time in the future when you compare it to the endoscopic therapies. We also have all of these other potential adverse events and other potential issues. We are going to talk about the GI side effects in a minute, but then there are some other things that are a little less common. The cholelithiasis, pancreatitis, thyroid cancer, worsening of depression and suicidal ideation, hypoglycemia, acute kidney injury. There's still issues with insufficient supply, and then the insurance coverage. And cash pay is still really expensive. This is a recent analysis that was published just last year, and they looked at patients who were on GLP-1 receptor agonists versus patients who were on another weight loss drug, the combination of bupropion and naltrexone, which is Contrave. And comparing those patients, they saw that there was a significant, even in the adjusted analysis, there was essentially 9 times the number of patients that had pancreatitis, a significant increase in bowel obstruction, and of course the gastroparesis that we've known before. But these are all things that we need to talk about when we're talking to patients about these things. The other thing is that, that the issue of residual gastric content. So there are multiple studies that have now looked at these things. And in a nationwide claims database, there was of 6.8 million people looking at GLP-1 users versus DPPI-4 users. And opioid users, is that there wasn't a significant difference in aspiration pneumonia, or pneumonia or respiratory failure with either of the 2 uses for diabetes. And there was no difference in respiratory failure or pneumonia for patients who had GLP-1 use versus opioids. And in a multi-center analysis, there was an increase in retained gastric contents, but there were no increases in aspiration events. Furthermore, patients taking PrEP for colonoscopy are protected, and in a meta-analysis that looked at over 84,000 patients, there was a higher rate of aborted procedures because of content still being in the stomach, but overall there was no difference in AE rate or aspiration rate. So putting all of this data together is that there is possibly a decrease in retained gastric contents if you stop the medication a week before. But there's no consistent evidence of increased risk of aspiration of not stopping versus stopping the GLP-1 receptor agonist prior to endoscopy. And I would argue that if this is really slowing gastric emptying, we have other disease processes that are like this, right? Gastroparesis being one of them. And we would manage those patients by putting them on a prolonged liquid diet before doing a procedure. Medicare plans also now cover Wegovy, and that is because of this increased risk, or because of the SELECT trial that I showed you before, that even though there wasn't as much weight loss as we saw in the other trials, it did demonstrate a difference in cardiovascular risk. And so that is now an indication. Medicare by law cannot cover weight loss drugs, and based off of the data that we're seeing now in other disease processes, in particular MASH, that we are likely to see these drugs being covered by Medicare for the treatment of other diseases, not specifically obesity. A word about compounded semaglutide or tirzepatide. FDA has warned against this, and that is for a number of reasons. One is because of issues with the drug purity itself. The other issue is that there are many cases where they give patients a multi-dose vial, and patients are overdosing themselves, and they're getting very sick and requiring hospitalization. So due to these risks, many practices are now following FDA guidance and are not prescribing to these compounding pharmacies. So just a couple of quick words on prescribing GLP-1 or GLP-1 GIP receptor agonist for obesity. So we first identify possible contraindications. So if they have a history of MEN2 or medullary thyroid cancer, or if they have a family history of this, I still discuss overall potential risks for any thyroid cancer with patients, but the risks are pretty small if they don't have the family history. We talk about gallbladder disease and whether or not they've had a cholecystectomy already. History of pancreatitis. No, this isn't absolute, but I would tend to stay away from this drug if patients have had pancreatitis in the past. If they've had a history of small bowel obstruction, again, this isn't in the labeling, but I do talk to the patients about the data because they are at risk anyway for repeat small bowel obstruction. And then for gastroparesis, I have actually had issues in patients who had baseline gastroparesis, but it's not a strict contraindication for patients, especially if their gastroparesis is mild or pretty well controlled. Other potential issues, if they have a history of kidney disease, they have a higher risk of getting acute kidney injury with nausea and vomiting in the setting of chronic kidney disease. It can cause an increased heart rate. There's this possible effect on suicidal ideation. If they have a history of depression, I talk to them about this. And I personally do perform patient health questionnaires, the PHQ-9, which is just for depression at my visits when I'm doing weight loss. And then hypoglycemia, it's more likely in the setting of insulin. I usually do, if a patient is on insulin because they are on diabetes, I usually require the physician who is managing their insulin to actually start their GLP-1 receptor agonist and to manage that insulin because I don't have the ability to do that in my clinic. We've kind of talked about the risks and benefits already, the weight loss that we see, and then the downsides that we have with the side effects, and so I discuss that with my patients. When we're going over dosing, this is a dose escalation. You're starting at the low doses, and you have these GI side effects that are mainly due to the GLP-1 component, but all of these drugs will have to have the GLP-1 component because the GLP-1 component is what is counteracting the negative components of both GIP and glucagon. So you start at the lowest dose, at least 4 weeks before dose escalation, hold the current dose if the side effects persist, drop back down to the next tolerable dose if side effects are not tolerable despite treatment. In managing these side effects, I kind of really gravitate towards the easy things first and then increase to the prescriptions when needed. So we start out for nausea and vomiting, really starting with like peppermint, smelling alcohol swabs, low residue diet, and then we escalate to like a Zofran anti-nausea medication if we needed. For abdominal pain, same thing. I really do use peppermint a lot actually for nausea and abdominal pain in patients. But if they have moderate to severe pain, I'm more concerned about pancreatitis and I will get labs and potentially imaging in those patients. And constipation and diarrhea, manage those like you normally would in your practice. So in summary, gut hormones play an important role in the pathophysiology of obesity. Multiple gut hormone receptor agonists are available now, and they are multiple in studies. And the drugs treat obesity and obesity-related diseases. There are multiple issues with the medications that should be discussed with patients, but for the majority of patients, we are able to do dose escalation and get them to the maximum tolerable dose. Thank you.
Thank you so much, Shelby. That was a very thorough review of the entire field, so well done. And I thought we'd have a little bit of time for a panel discussion and Q&A at the end. So next up, Dr. Abadeo, he'll speak about endoscopic bariatric therapies from balloons to gastroplasty. So when and for whom?
Thank you, Viv. Thank you, colleagues, for making it to this exciting sessions. For decades, if not more, we dreamed about the era where we as gastroenterologists could be playing a major role in managing obesity and metabolic disease and having the impact on society and the healthcare of the globe, actually, by managing these diseases. And I think the era is now. And gratitude to Boston Scientific and other industry collaborators who are pushing forward with this field together in order to make a huge impact on patient care. These are my disclosures. Before we start diving into the topic, it's very important to highlight why is it important for us as gastroenterologists to be dealing with obesity and metabolic disease. The simple answer is the disease is GI-centric. The pathophysiology starts from the gut, and the therapies are in the gut, and now we have the tools to administer effective, potentially disease-modifying therapies using the gut as a therapeutic target. So for a while, we had this treatment gap to justify why we need to develop endoscopic options for the management of the disease. And the gap was simply bridging the gap between surgical interventions and lifestyle interventions. And we have responded to fill this gap, and as Dr. Sullivan highlighted, with medications and with endoscopic bariatric therapies. And now we're going to be talking about next generation endoscopic surgical options to even take the safety and efficacy of these interventions even further. But the real gap is not that gap between medical and surgical management. The gap is a gap of access, gap of value, what's the value that we could be providing to patient care, and gap of acceptance, because in this current day and age, only 1% of patients eligible for an obesity interventions do get this intervention because of the multiple gaps. And that's where endoscopy is very well positioned to manage these gaps. The numbers are simply scary. We ran out of shades of red to describe the magnitude of the problem in the United States. And now we have to introduce a color that does not match. We're introducing this blue magenta color to show that the prevalence of disease is going to be pushing 60% by 2030. That means more than half of the population will have the disease. So let's dwell on that number. It's quite impressive. So what's the value proposition of endoscopic bariatric metabolic therapy? Again, we said it's an issue of access, it's an issue of value, and it's an issue of patient acceptance. And with endoscopy, we check all these points. Patients do not want to get surgery because they do not want to treat one disease and remove an organ. So we have an organ-sparing strategy to manage this disease using the same targets as surgery. These interventions are safe and effective, and we're pushing the safety and efficacy boundaries every day as we develop new tools and new techniques to manage this disease. Again, you do not want to treat obesity and get gastroesophageal reflux. So you don't want to treat one disease and get another. And so far, the endoscopic therapy had no long-lasting effects or adverse effects on health. And very important, they're minimally disruptive to the patient's lifestyle, because the only effective treatment for obesity is the one that the patient could follow, and it would maximize compliance, and endoscopic options are lending themselves well to this strategy. So the current endoscopic bariatric and metabolic therapies available in the US market are intragastric balloons, and I'm not going to belabor these because of the limited time that we have. And the other one is endoscopic sleeve gastroplasty. And with endoscopic sleeve gastroplasty, we're now living in an era where you could walk to an outpatient endoscopy unit, Somebody could put a sewing machine in your mouth, and you could reduce the capacity of your stomach by 80% in order to manage obesity, and you'll walk out from that endoscopy unit in about a couple of hours, and you're out and about in 2 to 3 days, resuming your daily activities. So this is the procedure. It's endoscopic sleeve gastroplasty. We're using this full-thickness endoscopic suturing device to imbricate the greater curvature of the stomach to create a tubular structure. So the stomach gets shorter and tubularized, and these anatomic manipulation result in physiological changes that impact appetite. So you're impacting the accommodation of the stomach, so you're impacting satiation, and you're impacting the emptying of the stomach, so you're impacting satiety. So these anatomic manipulation result in physiological changes in gastric physiology, resulting in changes in appetite that allow you to lose weight. And so this procedure is performed by the overstitch device. This is the first the Gen 2 of this device. And as you could see, this you start the procedure by going to the junction between the body and the antrum at the level of the incisura. And you're using a helical retractor to acquire the full thickness of the gastric wall. And you're introducing this U-shaped suturing pattern that allow you to shorten the longitudinal length of the stomach and to tubularize the greater curvature. Usually, you could see with each sequence of these U-shaped or O-shaped sutures, you're shrinking the length and tubularizing the stomach, and you're introducing about 6 to 8 of these plications in order to create an endoscopic sleeve gastroplasty that is shortened stomach with a tubularized greater curvature and a small pouch in the fundus that will accommodate to the food. And again, this is not in theory. We've studied the physiology of this procedure. This is published in Gut, where we use functional MRI, and you could see with a functional MRI, you get the shape that I showed you in a cartoon. This is at 6 months after the procedure. You have an imbricated greater curvature of the stomach, significantly reduced capacity of the stomach, small pouch in the fundus to accommodate quickly and allow you to terminate the meal early, and you have alteration in the emptying of the stomach, but you do not have this motility. You could see that the antral pump is still working well because you have an innervatic stomach that is still functioning with a delay in gastric emptying. And if you want to learn more about the physiology of how this procedure works, I would refer you to this publication. So now, what's the state of the evidence about endoscopic sleeve gastroplasty? Again, very robust. I don't think we have an endoscopic intervention that went through the rigors of all these studies, as we have with the ESG, about 15,000 cases in the published literature, very low rate of serious adverse events at about 1.25%, so it's similar to any interventional endoscopy procedure. 12 months weight loss, cumulative is about 17.5% total body weight loss. The weight loss is durable at 24 months, and we have reasonable data at 36 months to show durability at that time horizon, which definitely now we have an endoscopic intervention that is a one-time intervention that is competing with the weight loss results of the drugs that Dr. Sullivan have discussed with you. So based on the state of the evidence and based on a large randomized trial published in The Lancet, including multiple US centers, Orlando Health was one of the major centers in this trial, so it included both gastroenterologists, bariatric surgeons in community and in academia. The FDA issued market authorization for the use of endoscopic sleeve gastroplasty for the management of obesity in patients with a body mass index between 30 to 50 who have not been able to lose or maintain weight loss through more conservative measures. And now, with this state of the evidence, the National Institute for Health and Care Excellence in the NHS have evaluated the evidence and recommended introduction of ESG as a procedure in the UK. We've seen that the Washington State Health Authority also approved it as a covered benefit in the state of Washington. And now we're having increased momentum with societies issuing guidelines recommending the use of these endoscopic interventions, both endoscopic societies and now even surgical society. This is an EFSO, World Gastro Organization guidelines that included the use of ESG for the management of obesity. Now, when I started this, we talked about what is the real issue. The real issue is value added to obesity and metabolic care, and how do we compete with these medications that Dr. Sullivan have highlighted. Definitely the medication is something that we should celebrate. More treatment for more patients is always something good when you have 99.9% of the population not being treated. The medications do result in about 15 to 20% total body weight loss, as shown here. With this degree of weight loss, regardless of the mechanism of action, you would see significant improvement in metabolic profiles, but the medications have a limitation. Early discontinuation because side effects is a limitation. Tachyphylaxis and the patient getting used to them is a limitation, and we know that about 50 to 60% of patients will not continue these medications beyond the first 6 months or so. There is also the issue of cost. And if we now superimpose endoscopic sleeve gastroplasty as a procedure to compete with the value of these medications, you could see that the weight loss is similar and even more than some of these medications at a 36 months horizon. Also results in a similar metabolic benefit that you would expect from this degree of weight loss with a low serious adverse events, less compliance from the patient because you got the procedure so you don't need to remember to take any injectables, and the cost effectiveness is there, and there has been multiple cost effectiveness analysis. This is published in Gut by Dr. Shariha and her team, showing that for patients with class 1 obesity, ESG is the most cost effective compared to surgery or medication. For patients with class 2 or 3 obesity, laparoscopic sleeve gastrectomy is the most cost-effective, but ESG remained cost-effective in all classes of obesity. And for semaglutide to be cost-effective when compared to ESG for class 1, it has to cost $297 annually, and right now we're looking $1,200 or $1,100 per month. So there's a long way to go before this becomes cost-effective. Similar cost-effectiveness analysis that Dr. Sullivan alluded to in her slide, so I'm not going to belabor this, but this is published in JAMA Open Network that showed similar conclusion to the one in the Gut. So now we're seeing momentum. We're seeing valid procedures that could be scalable, and now we're getting momentum with giving patient access to this procedure, and now we're in the process of getting codes and coverage to allow for payments and wide adoptions of these techniques. But what's coming in the horizon? And that's where we need to continue to push innovation, because this field could be transformative to the discipline of gastroenterology. And if we don't have industry pushing, if we're not pushing and leading this field, we're going to fall behind, and there's a lot to come in this field. And so I'm going to give you some of the innovation that's coming in this field. Combination with medication is going to be a pillar of the future. We published this as part of a multi-center trial in the commercial experience of using ESG in the United States. And we wanted to see what's a subgroup analysis of combination with medications. So here we had 1,500 patients, and most of them did not use anti-obesity medications, but about 150 of them did use anti-obesity medication across 7 US centers with a follow-up of 2 years. You could see that with ESG, with no medications, at 2 years you had 15.4% total body weight loss. Of course, those who started medications within the first year, these were the suboptimal responders. So you could see that adding medication in the first year improved their weight loss to become more of an average weight loss of what you expect with ESG. But the real story happens in what happens after first 12 months. So those who started a medication after 12 months from ESG, at 2 years ended up having 21.1% total body weight loss. And not all of these medications were the GLP-1 agonists. Many of these medications were the cheaper alternatives. So that means if you engage the patient in a multidisciplinary program after the first year of ESG, you'd expect results that could be equivalent to bariatric surgery as far as efficacy in the long-term horizon. So the next innovation is next-generation suturing and technique. We talked about the Gen 2 device. This device now is available. This is called the NXT suturing device. It has two advantages, or multiple advantages, but a couple of the important advantages. It allows you to articulate in very difficult angles, so you could access more of the stomach for intervention. And the physician is controlling the helical retractor in plane with the suturing device. So acquiring full thickness plication is very, very easy with this device. And here you could see this clutch function of this device allowing you to articulate very difficult angles in the stomach and do maneuvers that we simply could not do with older generation of the suturing. So with this device, we start working on improvement of the technique itself. The current way we do ESG is like we're putting the anterior posterior wall with two fingers coming together. And now with this device, we could do interlocking ESG. It's just like these fingers now interlocking to maximize the healing of the surfaces. And then you interlock the sutures in order to create a more robust plication as shown here. So that each layer of this plication have 6 layers of proline coming back and forth. And that is what we're calling as interlocking ESG. So this is doing an interlocking ESG with the NXT device, and you could see here's one of the sequences that we just interlocked with about 6 layers of proline with 1 suture, actually, so you can cut down on the number of sutures, and you could see after you cinch that system is now there's these projection interlocking like fingers together, supported by multiple layers of proline, improving significantly the durability of these plication. And here is just want to show you the sequence of doing full thickness plication with the NXT device. It's very easy to get full thickness with high fidelity. Almost every bite is full thickness because of the function of this helical retractor being in plane with the suturing arm and the articulation function of that device itself. So now when we looked at, if you look at the durability of this interlocking pattern, you could see at 6 months, you have 100% suture retention. The plication line is completely intact. You do not lose any sutures. And we're not just looking at that with endoscopy. We're looking at that with MRI. And that's one of the patient's MRIs that looked at this interlocking ESG pattern. And you could see a nice sleeve line and plication of the greater curvature. So the technique and the procedure continue to evolve in order now to push weight loss that is very equivalent to what you get with surgical sleeve gastrectomy. And this is looking at the interlocking ESG versus standard ESG. We presented that at DDW, showing that with this interlocking pattern, the weight loss on average is surpassing 20% at 6 months. So other advancement in this field, stomach works on restriction and weight loss, but the small intestines work on metabolic disease and diabetes. And now we're going to have the tools in order to combine both interventions of the small intestines and on the stomach in order to manage advanced diabetes or a diabetes with severe obesity, where you could start the procedure by regenerating the small intestines to reestablish metabolic health, and at the same session, doing a same session restrictive procedure on the stomach to affect appetite, so you're getting the metabolic improvement and the weight loss to manage advanced diabetes. We're also going to be pushing the limit where we're going to be doing surgical endoscopy for diabetes. This procedure, the mini gastric bypass, is a single anastomosis gastric bypass that has very robust diabetes benefit. Now we have the tools to recreate the components of a single anastomosis gastric bypass endoscopically. So we now could do a EUS-guided gastrojejunostomy. We're working on a device to occlude half of the stomach and bypass the duodenum, and you could reduce the rest of the stomach using an ESG approach, and now you have the same components of a single anastomosis gastric bypass. This is a device that we're working with Boston on, where you create a anastomosis with an axios or surgical anastomosis. You pull a device like a peg tube from the mouth, and the device is occluding half of the stomach, bypassing the small intestines, and creating a single anastomosis gastrointestinal bypass. So the conclusion here is we as gastroenterologists should own this disease. We should be central part in managing it because the disease is GI-centric and we have the tools to manage it effectively. So I hope I gave you a glimpse of what we have now and what's coming in the future, and looking forward to the discussion. Thank you for your kind attention.
Thank you very much, Baham. So I'll be speaking very briefly about the endoscopic management of complications of bariatric surgery. So, I went to a recent bariatric surgical meeting, ASMBS, and I must say the surgeons are very concerned. Many surgeons who are only performing bariatric surgery are now having to perform sort of other foregut surgeries because of the volume reductions. And so I think, aside from AI, probably the obesity medications have been the most transformative thing to our society in the last 2 years. So, I'll be zipping through in about 10 minutes just to catch up on time here. So let's see how much we get through. So bleeding is not just a complication of bariatric surgery, but a complication of much of what we see. And, we may not see a whole lot of live endoscopic suturing cases here, so I thought I'd show you some videos. One thing about sort of the complication space is that there really isn't high-quality data, and so a lot of case series, all retrospective, and so I think videos will probably teach us as much as anything. This is a chronic marginal ulcer after a gastric bypass. I don't see how clips could close this. There's a visible vessel there, and I thought I'd be diligent and do some sort of two-approach technique where I inject epi first, and then I do an endoscopic suturing procedure where I oversew the ulcer, basically taking jejunal tissue and dumping it in that ulcer bed to try and tampen out and compress. Now, unfortunately, I nicked that vessel. And so was left to deal with this, and I thought suturing would be my only play. When you're in a post-gastric bypass anatomy, you've got a very small pouch. It fills up with blood incredibly quickly. You can use your view, so you need to sort of act quickly here and obviously have the patient intubated. But we basically ran a running suture pattern from left to right, and you'll see here that during the suturing process, you can actually put some tension on the suture itself, and you can actually compress tissue and stop the bleeding even before you've completed your plication. So this was a chronic ulcer, but yet after we oversewed it, sort of quite curiously, at 6 weeks follow-up for the first time, this ulcer had completely healed. And so that sort of prompted us to ask, maybe oversewing these ulcers with suturing may be a mechanism to manage these recalcitrant ulcers at the marginal zone after bypass. Just touching on weight regain post-Roux-en-Y gastric bypass, one could consider that a natural course of surgery, or could also consider it a complication. And so the image on the top left is a 40 millimeter gastrojejunal anastomotic aperture. I APC'd it, then I did a pretty robust running suture, and you can see on the top right, on completion of the case, what it looked like. Brought the patient back in 8 weeks, and you can see that we got some really nice closure there and some nice fibrosis. What was fascinating is that this patient presented with dumping syndrome as much as they did weight loss, and they came back a year later, and that was their aperture again. So despite doing everything technically right and having a good response initially, the normalization of anatomy is something we just need to keep in mind for any bariatric surgical or endobariatric procedure. And you see that in their weight trends as well. When you do these outlet reductions in patients who have a gastric bypass, you lose about 10% of your total body weight, and you start to see that regain again, and you often need to keep bringing these patients back. It's the interest of the time, I won't really show you a video of how we do the procedure. Perhaps the most important part of this talk is recognizing this concept of functional stenosis. So often unrecognized, and I'll try and illustrate it to you with this case. So this is a 56-year-old male who had sort of nausea, vomiting, and abdominal pain about a year and a half after this surgical sleeve gastrectomy. They had 7 endoscopies over this time, and all of them said this is a normal stomach. However, they had an upper GI series which commented on a distal stenosis, a stenosis at the incisura angularis. And so this is the endoscopic fly-through here. So you see a non-compliant, stiff, thin tube, and then you see something that looks a bit abnormal at the level of the incisura. And I think I'm a pretty reasonable endoscopist, but I had to work to get through to the antrum here. And sort of it signifies that manipulation, that torquing and twisting of the scope is not particularly normal. And then when I retroflexed in the antrum, you can see the twisting of the tissue around that scope. So this, despite the scope getting through, this behaves as a stenosis. And if you see here, when you inject contrast under pressure, it flies straight back up into the esophagus. And so this is a very high pressure system that we have to deal with. And we can drive a 30 millimeter or 35 millimeter achalasia balloon across the stenosis, and you can convince yourself that you straighten things up just a little bit here. So very important to recognize this concept of a functional stenosis. And again here, this is a post-sleeve gastrectomy patient, downstream stenosis, massive dilation of the upstream stomach. Contrast isn't getting through, but the scope gets through, no problems at all. So put a Rigiflex balloon down and inflate it. When you're doing this procedure, on the bottom middle image, one thing to keep in mind is that you want to see this ischemic ring that you can see there, and that tells you that you're across the stricture and that you're in fact not imagining this potential stricture. If you look at the image on the top left, you might be able to appreciate that staple line sort of rotating around. It starts on the left and it's actually going to swing around. And if you look in the antrum, that staple line is going to be at the 4 o'clock position on the right-hand side. And so this is a torsion of the stomach. But you've got to be careful. And so if you don't see that discrete ischemic ring, but you see the entire stomach start to blanch, you probably don't have a sleeve lumen caliber sufficient enough to do an aggressive dilation. When the surgeons do a surgical sleeve, they size it to about 40 French, so about 14 millimeters, and here we're using 30 millimeter balloons. And when you tear or perforate with these balloons, it's not a 10 millimeter perforation, it's a several centimeter perforation. And so we were able to suture this up. This is another case of a patient who had sort of inability to tolerate the saliva 4 days after a laparoscopic sleeve. And when I looked down with the scope, I actually couldn't tell where the lumen was. You wouldn't believe it, but it's actually at the 7 o'clock position here. And there's a massive twist. So the tip of the scope is the proximal end of that stent that I deployed, and it swings all the way around. And so you can be impressed by how significant this twist can be. So we put a partially covered stent in here, left it in for 3 weeks, pulled it out, and because this was very early in the course, we actually managed to straighten the sleeve out pretty well. And so we thought, is there another way of addressing this stenosis, this twist? If the twist is sort of maintaining its shape primarily because of the muscle behavior of the stomach, maybe if we do a myotomy of the stomach, we could potentially unravel this twist. And we've been doing this since 2015. So again, here's a case of a patient that I wanted to do a conventional pneumatic dilation of, but you can see a blanching of the entire stomach. This was not suitable to proceed in this manner. And so we did a G-POEM, and the POEM procedure is actually very tough. They're long tunnels, and it's a twisted stomach. So you actually start with the muscle at your 6 o'clock, and during your tunneling through the stenosis, the muscle will swing around completely, 360 degrees sometimes. It can be very easy to cause a mucosal injury. And sort of, as we've done this over time, there's 2 types of stenoses to remember. The top left is a demonstration of this helical stenosis, this aggressive twist of the stomach, whereas the bottom is simply a situation where the surgeon, the staple line isn't twisted, the surgeon just dropped their staple gun a little too close to the incisura angularis, and there just simply isn't much space there. And so doing a G-POEM on that sort of bottom image is probably not going to help you. There's no sort of true torsion, but on the top image it seems to help. And so again, we did that, and sort of proposed this algorithm where if you have a sort of endoscopic and radiological evidence of a stenosis, decide if it's helical or non-helical. If it's non-helical, you're probably going to end up having a conversion to a gastric bypass. If it's helical, you could try pneumatic dilation, maybe a G-POEM, and if that doesn't work, then the bypass. Just to show you the impact of this functional stenosis on pressures, this is a patient who had a sleeve leak for over a year from memory. You can see that there's a blowout of a staple line and very proximal aspect of the stomach, and immediately downstream from that blowout, you see a tight stenosis. And so there's nothing we are ever going to be able to do to close this hole unless we address that stenosis. And so again, we did a G-POEM. We had to start in the esophagus because of the proximal nature of of the stenosis. You don't want to cut the muscle of the LES, and as someone who's got a surgical sleeve, they'll get bad reflux. So we have to tunnel through, but not disrupt the LES. We can close conventionally, and you wouldn't believe it. This is at the end of the procedure. This is not months later. Immediately at the end of the procedure, we inject contrast. You can see the esophagus is far less dilated. The pressures change, and there's actually nothing flowing through that hole. The hole exists. I could see it with the endoscope, but the pressure dynamics were so different. But just wanted to sort of trigger our thoughts into thinking about things a little above and beyond simply anatomical. And so if you remember, the gastric pacemaker resides in the sort of proximal anterior part of the gastric body. And that's resected at the surgical sleeve. And so sometimes you'll see that there's aberrant firing. There'll be new pacemakers that start firing elsewhere in the stomach. And this was a nice surgical study where they placed this electrode mapping system on the stomach, sort of pre and post surgery. And in a normal stomach, you get sort of firing antegrade from esophagus to pylorus. But in this post-surgical patient who had severe reflux, there was actually probably an ectopic pacemaker in the antrum that was causing rapid retrograde contractions. And so you can dilate all day long, but nothing's going to make a difference here, and this patient's probably going to need a bypass. So just in the final minute here, we'll speak briefly about leaks. So I'll have to skip through the videos, but generally primary closure doesn't work well unless the leak is sort of is tiny, within 2 weeks, and there's no downstream stenosis. So here you can see on the barium study that there is really no stenosis of the stomach and a tiny hole. So we did a primary closure, and that worked. Generally, we use stents, and when we use stents, I tend to favor partially covered stents, but this can be a topic for the panel discussion as well. The Boston Wallflex stent seems to be really good, quite robust, because when you pull it out, you have to work pretty hard at it. And so, the surgeons, every time I send a patient back saying there's nothing I can do to help this patient, they send it back to me and say, keep going. And so this is a patient who had complete dehiscence of the jejunum off their pouch. So we somehow managed to find the jejunum. There's a huge defect there. We dropped a wire and we placed a partially covered stent. And the stent deployed well. The pigtail is the start of that dehiscence. And then we usually pop a suture here because there's no true stricture, and so there is a risk of migration. And so we came back 4 weeks later, and the way I removed these stents, you can see here that we inject contrast. It's actually got a really nice watertight seal, and that's the value of the partially covered stent. Not only its migration, but it actually causes that watertight seal, which may be important. And so you've got to grab the distal end of the stent, you twist, and then you've got to bring it out. And you can't sort of give up halfway when it gets hard or when you're feeling a lot of pressure. Otherwise, you end up with a stent that's partially involuted in the esophagus, which doesn't help anyone. So you grab it, you twist, you pull, and you end up sort of feeling a lot of resistance here, and you feel the tissue tear, as you can see on that stent. But and then you go back down, close your eyes, inject contrast, don't see a leak because there's sort of blood everywhere. It doesn't look good. But you'll see here, we salvaged this patient, right, from this simple stent. And so it's very interesting. This idea of a septotomy is very clever, came from Brazil. Sort of, again, it's all about pressures, these adverse events. And so sort of think about a leak like a Zenker's diverticulum. You've got the gastric lumen on the right, the chronic leak side on the left, and let's just disrupt that entire staple line down into the base of that perigastric cavity. So this is helpful when the cavity is sort of surrounding the stomach, and then address any downstream stenosis with a dilation. And despite this looking ugly, this is not functioning as a leak anymore, and the patient can eat and drink, and they feel great. So I want to show you that. Maybe last is endoscopic vacuum therapy, starting to gain favor as a salvage approach. You can actually just drop the sponge in the lumen, or if you can, get it into the defect. The challenge here is that because of all the gastric residue and salivary residue, you have to change the sponge every 3 to 5 days, and it's a lot of work, an average of 11 procedures. But it can be a useful sort of final step. And sort of last slide here is sort of this idea of using a cardiac septal occluder. And so if you can't if you've really got nothing left and the patient's doing poorly, can you just drop this sort of dumbbell-shaped stent that's used to treat ASDs or ventricular septal defects? And this is a patient that had stents, over-the-scope clips, as you can see, and we eventually just dropped, almost misdeployed it, by the way, and dropped this cardiac septal occluder, and we left it there, and the patient seemed to do fine. So anyway, I'll stop there and just move to the Q&A here, just in the final minute or two, if we're allowed, Dr. Hawes. All right. Well, thanks. So if any questions from the audience, happy to take them. But just had a question for the panel. Should every patient who's interested in losing weight be started on pharmaceutical therapies first?
No. I don't know if this is on. Okay. No, I don't think so. I think it really is a shared medical decision-making with patients, because you will have patients that come into your office that say, I don't want to be on a medication for the rest of my life. I want to get off of medications. But conversely, you have patients that don't want to take the risk of even a procedure, or, and definitely don't want to take the risk of a surgery. So I think it's shared medical decision-making, but definitely I don't think patients should be forced to do a medication first before something else.
Yeah, I agree. And there's some thoughts that inherently endoscopy is riskier than medication, where there's some truth to that. If I showed you a procedure with a serious adverse events rate of 1.2%, outpatient procedure, takes 45 minutes to an hour, and it could save you money and save you injections, why are we saying it's a step-up approach rather than pillars of treatment? So it should be shared decision-making, and the value proposition should be highlighted. And I think people will gravitate to an intervention that they could follow. And if it's covered, I would bet you that way more people will pick to start with endoscopy because of the less compliance issues than they would do with medications and the risk that comes with them.
From my perspective, the one thing I've learned sort of over my career is that insurance companies are very, very, very reticent to unleash sort of coverage for a procedure that they sort of can't control. And I think I congratulate Barham and everybody else who is doing the work on durability of this procedure. But we went through a really tough time with anti-reflux procedures, and I remember being in endless meetings where the startup company would say, well, this is really easy to do, and so if you get your reflux back in 6 months or a year, we just redo you, and what's the big deal, and so forth. But insurance companies are absolutely dead set against that. And I think it causes great fear and trepidation to say, okay, we're gonna cover sleeve gastrectomy, and now everybody is gonna go out, get the Apollo suturing device. It's not gonna be as standardized. They're gonna not do a good job. The patients are not gonna lose weight. No, well, just come back and I'll redo your. It's a situation that they can't control, and I think that's one of the big inhibitions to getting this covered. And I think you talk about expanding, ESG, but the fact of the matter is that you're in the same spot as the surgeons are. There's, I have 30 or 40 of you who are fantastic at this, but that's not going to make a dent in obesity. And so somehow, I think coverage and then getting a sufficient number of people who are doing a competent job are the two maybe rate-limiting steps to really this making a big impact on obesity.
Yeah, I agree. And, I think the bariatric surgeons address this by having their registry, the MBSA QUIP, and some insurance companies will only cover a patient who's having a procedure in a hospital that is part of this registry. And so maybe that's something that we could look at.
Is that movement going on amongst?
We currently are working on the GI Quick is working on an endoscopic metabolic and bariatric therapy registry. I don't know how much more I can tell you about it, but we are working on this not only for multiple different reasons, but what you just talked about was it's absolutely true. I have talked to multiple insurance companies. They want to have a way to do QA/QI in order to make sure that procedures are being done in places where they're monitoring their effectiveness. The other thing that goes along with it, though, is that we also want to be able to use registries in order to broaden indications, so that you get additional FDA indications by using a registry too.
Bob, to the counter argument to yours is the following argument. We know that none of the currently approved medication actually modify the disease pathophysiology. So that means you gain the weight with a medication like semaglutide, and you get off of it. When you get off of it, your diabetes is going to worsen back to its original state. That does not happen when you're using gut-based therapeutics. That means you could get a gastric bypass, you could gain all the weight plus tax, and you will not have your diabetes back in 60% of the time. So fundamentally, we're sitting on a gold mine where we could not talk about chronic disease management, but we could talk about chronic disease modification to reverse the clock on chronic diseases. That could be transformative, because we could be impacting a whole slew of interventions that could modify the disease progression and its complications, not just manage it and kicking the can down the road. And that's where understanding the physiology of the GI tract, its role in immunity, in chronic inflammation, all these are therapeutic targets that we already know that they work from what we know from bariatric surgery, and now we have the tools to replicate a lot of this benefit endoscopically, which is a differentiator from drug therapy for the disease.
Thank you. We've got a question now from the audience, and then we'll probably close.
Yeah, it's simple. When you counsel these people for the drug therapy, do you stress to them that this is a lifelong kind of thing?
Absolutely.
And they do it anyway?
Yeah. I mean,
And then they stop.
So I talk to them about that, just like I would say, if you have high blood pressure and you take a blood pressure medication and then your blood pressure is normal, it's because you're on the blood pressure medication. So you can never, the same thing is going to be true for this obesity medication. You can never stop it. If you do, your weight is going to come back on. The interesting thing is that probably only about 15% of the public actually know that that's the case. They think that, I'm going to do this as like a jump start. No, it's not a jump start. It's got to be lifelong.
A question at the back there.
Hello, can you hear me? Yeah. Fantastic presentations and lectures and discussion. Just to Rob's point, we've seen some recent news about a robotic endoscopic sleeve gastroplasty, the EndoZip. Just curious if what you think that could potentially impact down the road to provide this type of procedure to more patients. Is this something that you think where literally they come into an endo center and any, gastroenterologist has the ability to just send this EndoZip down? Maybe you can describe it, but press the button and voila, the sleeve is done. You want to comment on that?
It's a suction-based robotic suturing system. I think conceptually, this idea of disseminating technology and improving access, as Baham mentioned, is one of the high-value targets for our field. I don't know EndoZip may be it. I have my feelings about it, but I think this idea of simplifying a procedure, making it agnostic to expertise in the same way that AI sort of improves skill level for certain detection and characterization of lesions, I think is one of the goals for us in the endobariatric space. So I think it is important. The less sort of manual we have to be, the more consistent our outcomes and the safer it is as we disseminate.
And to this point, the important concept is how to support innovation. EndoZip is an innovation in the field, and there's going to be a whole slew of other innovations. But if we do not have a platform where we could garner these innovations, cultivate them to make them viable, then we don't have a field. So for sure, now since there's momentum in this field, the innovation, there's a whole list of very cool technologies coming down the pipeline. But I think it's where do we start? We need to get traction with what we have, build the field, emphasize quality, and continue to support innovations with industry partners.
I think we've got to close this session. I want to thank Vivek and Barham and Shelby and many, many thanks to Boston Scientific for putting this together. I think this is really one of the forefront issues in gastrointestinal endoscopy, and I'm grateful for all of you really talking about it and so forth. So this ends today's session. I appreciate all of you staying. We've run over time, but I think it was worthwhile to see the cases and for the symposium.